begin my presentation. Do I have the ability to share my screen? I think so. Okay. So share screen. There, I hope that is working for everyone. So I will be talking about preterm growth, preterm infant growth expectations with a focus on extrauterine growth restriction. So let's start with a poll. So I ask that you answer these questions for yourself, and then we'll see at the end of this session if I may have changed. So perhaps write down a piece of paper or in your phone what your answers are, and you can compare them at the end. So the first is, are failing by discharge, true or false? Number 2, preterm infant growth expectations vary with birth size, genetic potential, and NICU course. 3, infants with growth without growth restriction. And number 4, most preterm infants should regain their birth percentile by 40 weeks of postmenstrual age. So, and a point that I'll be making today is that in neonatology as well as in pediatrics, there's been a tendency to be really concerned about the children who have weight below specific cut points. However, a point I'll try and make to you today is that there is a wide range of infant growth patterns that represent appropriate growth. So extrauterine growth restriction is a popular topic. It's usually defined as having a weight below the 10th or the 3rd percentile around the time of NICU discharge, around 36 to 40 weeks. This graph shows the occurrence of this phrase in Medline using the PubMed engine, and you can see it has almost an exponential growth over the past 20 years. It's become a very popular topic for people to publish about. And it's considered a neurodevelopmental indicator. And here's one quote by Timothy Stevens, where he wrote that extrauterine growth restriction is inversely related to neurodevelopmental outcome. But these authors assumed that EUGR is a problem, but didn't actually cite any evidence around discharge is associated with poor development. And evidence shows the opposite. A group of us worked together to write a paper with the reference at the bottom of the screen, where we make the point that there are 5 reasons why the term extrauterine growth restriction is not useful. And number 1, it's not predictive of poor outcomes. Number 2, it ignores the normal postnatal weight loss that place infants lower on growth charts. Number 3, it's based on arbitrary cutoffs. Number 4, and number 5, it doesn't consider other growth assessments such as head and length. So let's look at the evidence about the first one, about its predictability of poor outcomes. This slide summarizes 7 studies that actually asks this question: does extrauterine poor cognitive scores? And all of them found that it did not. It was not predictive. Most of these studies looked at the 3rd or the 10th percentile. We looked at across the range. We looked at all percentiles, and most of them around 36 weeks, some at 40 weeks. And most of them looked at Bailey scores. We also looked at 3-year IQ scores, which is a slightly better measure of cognitive outcomes. And none of these studies found an association between being below that percentile and poor cognitive outcomes. EUGR ignores normal postnatal weight loss that places infants lower on growth charts. This graph is showing growth patterns of preterm infants that are really the healthiest of infants. 25% of infants in some Canadian and German units were included, and they had to have no morbidities to boot it. They were all units that had nutrition protocolized. And I want to talk about what the graphs show. So the dark line in the middle of each is showing the median growth. The shaded area is showing the 25th to the 75th percentile with background. And this one is the 10th percentile. So what I'd like you to notice is that after preterm infants lose weight in their first days of life, these healthiest of infants, about 10th percentile, is essential for cognitive development. And I agree with you 100%. And there are some aspects of growth that have been consistently associated with poor cognitive development, and they are the slowest growing infants. For example, Richard Ehrenkrantz's work, he looked at the slowest growing quartile, or the slowest growing 25% of his group had poor cognitive outcomes. And then quite a few studies have documented that if infants don't catch up to be above the 3rd percentile by 24 months of corrected age, there is a higher likelihood that outcomes. Summarized the studies that document these findings in that same paper, same reference at the bottom of it. So I propose to you that because of all of these findings, that it's actually growth rates and longitudinal growth monitoring that are the better indicate long-term outcomes rather than one-time discharge measurements. So let's look at what the Europeans and the Americans in their guideline groups say. Now, you may have some national Pakistani guidelines, which I'd be interested to learn about. But anyway, so the Europeans recommend that the growth of preterm infants be similar to fetal, that preterm infant growth approximate the rate of growth of about approximating or being similar to, but looking at fetal growth as a guide. And growth charts such as mine show an estimate of fetal growth. So as I made the point initially, there is a concern in neonatology. Infants below certain cut points have problems, but the desirable growth patterns. So let's look at some of that range of growth patterns that are associated with good outcomes. This is a study that colleagues and I published 10 years ago now, where we looked at the individual patterns of 23 to 25 week infants in relative to my 2013 growth charts. I'd like you to notice there's the highest proportion of infants below the 3rd percentile or 10th percentile is around 36 to 38 weeks. And then infants start to catch up. And there, you can see that there is a very wide range of infant growth. They don't follow one pattern by any means. Let's look at the growth patterns of two appropriate. So the boy, they both lost some weight, fully parallel to the growth chart curves. Now this little boy maintained his weight above the 10th percentile. The little girl at 30, you can see that their length parallel to the growth chart curves. Their head circumference was approximately parallel, but was showing some increases. Even by term age, there was increases, some head sparing growth. So how would you evaluate these infants' growth? So my assessment of these babies is that they're both growing as this began and the American Academy's goals. So in my opinion, both of these babies are all for gestational. So their weights were lower at the start. This little boy lost weight and had a pretty routine shape of his growth pattern. He was parallel to the growth chart curves around the 3rd percentile once he started growing. This little girl didn't lose weight, or very little, and then started to percentile, even though her birth weight was below. Both of their length and head circumferences were desirable patterns, roughly parallel. So how would you rate these babies? Would you rate them the same, or would you say that one is doing poorer than the other? So my assessment is that both of these babies, like the other two, are growing as preterm babies grow, and they're growing well. Now the baby on the right did exceed her birth weight for small for gestational age babies do. In fact, there's a birth weight percentile by 40 weeks is 4 times more appropriate for gestational age baby. I want to tell you about a new paper that we have just published this week. A question about whether babies preterm babies who were small, only looked at preterm babies for this study. Indication at the bottom, the effect size here, it's numbers. I apologize for the small font, but you can see that there was no meaningful difference between the blood pressure to the appropriate for gestational age babies. Compared to appropriate for gestational age babies. The PubMed link is shown here if you're interested to read more. Now, this finding is contrary to a lot of beliefs about small for gestational age babies. So it'll be interesting to see what you think of this work. So going back to talk about those 2 small for gestational age babies. So if we were using that 10th percentile as a criterion, this boy would be considered. My assessment, they're both doing fine, and we wouldn't really expect a baby who is below the 10th at birth to be exceeding the 10th percentile later. Some do, but it's a rare occurrence. So born appropriate for gestational age at birth. And then she took a while to get growing, but she started growing, and she actually birth weight percentile by 40, even though she was appropriate for gestational age. Her length was in the upper percentiles, always above the 50th. 39 weeks, her head circumference was at the upper percentiles. So this baby, I'll give you a little bit more information. Her parents are tall, and she was growth restricted in utero. Now, we usually think of growth restriction babies as being small for gestational age, but she's genetically large, and so her weight probably should have been higher than like her head circumference, perhaps up near the 90th or 95th percent, gained weight more quickly than most preterm infants because she's genetically larger. So it's unlikely to happen for AGA babies, but it does occur. So I would rate her as growing well. It's rare for a non-SGA baby to regain their birth weight percentile, but it does occur occasionally. And I wouldn't reduce her nutrition. Her weight is not exceeding her head and length size. So I think she's doing very, very well. She'll continue to grow well. So now I'm showing you some large for gestational age babies and some additional information about these two. The one on the left is a healthy, large for gestational age baby with tall parents. The baby on the right, the mother had diabetes while she was pregnant. So you can see their growth patterns differ. This little boy lost weight and then started to gain. He did not regain his birth weight percentile, but he is in the upper. His length is growing roughly parallel to the curves. His head circumference had gone to the upper percentiles by 40 weeks. This little boy continued to fall off the growth curves. Now his length was maintained roughly parallel to the lower percentile curves. His head was starting to show a little bit of recovery towards 40 weeks. So how would you evaluate these two babies? In my assessment, they're growing well, but their genetic potentials differ. So the baby on the left has a large he's genetically on the larger size, not inappropriately. That's part of the range of normal. But the baby over here on the right, his weight was elevated relative to his length and head circumference, probably because he had some excess glycogen, which holds water, and fat at birth. And we wouldn't expect him to maintain those higher amounts. And over months, he would correct towards his genetic potential. He looked like a common preterm baby at this point, but he started with a higher birth weight. But that was a short-term event. To make is the size at birth is a clue about how a baby might grow. And in New Zealand, although they included people from around the world, they said infants with birth weights less than the 10th percentile may not be growth restricted, and infants with birth weights greater than the 10th percentile can be growth restricted. And so what we can take from that is that infants can be misclassified by their size at birth because pregnancy factors can alter growth. And then it's always nice to remind everyone that SGA, AGA, and LGA categories are arbitrary, and they can actually be wrong for the individual. A bit of guidance about growth expectations. We never really know a baby's genetic potential. We can guess at it. We can look at the baby's growth pattern. We can look at the parent's height. But the parents' heights aren't a perfect predictor either, because sometimes the child will take after their uncle for their size or some other. And then to set expectations for how an infant could grow, we need to consider any difficulties the baby has had before and after birth. And that's restriction or failure for growth, that we use faltering if we're really concerned about a baby's growth. So what does poor growth, what does faltering growth look like? So I just showed you 7 examples of good growth. So let's look at now 3 examples of excellent growth. Thing that you can notice right away is that his weight continued to fall away from the growth curves. His length also did the same. Now he's maintaining his head growth not too badly, but both weight and length are falling off. And I think you can guess that this baby needs some further investigations. This is not a satisfactory growth pattern at all. And is he one of these babies that you have trouble having him tolerate his nutrition, his growth pattern? And perhaps you need to call in some of your genetic and on. And what do you think of this baby's growth? So this baby's mother had diabetes, and I showed you his growth pattern earlier. He started out with it looked like his genetic potential suggested, and then he was around the 10th percentile, but after discharge, his weight is zooming upwards. What do you think about that? Now, I think that he may be being encouraged to take more feedings than perhaps he has appetite for. And if you're working in follow-up with a baby that's growing like this, it might be good to talk to the parents about recognizing feeding and satiety cues to help them feed the baby to his own needs. So there are needs to quantify growth for research and for clinical care, and they differ. Numbers on it and classify infants as growing well or poor. For clinical care, the focus needs to be a little bit more individualized, because every potential and what pregnancy factors might have altered in terms of their growth. I have references at the bottom, some of the papers where I searched. American Academy of Dietetics in the US has put out some guidelines by Goldberg and all in 2018, which I refer you to if you're interested. So let's come back to the poll. So again, and just for your own questions, any differently. So question number 1, most preterm infants are growth failing by discharge. What do you think, true or false? My assessment is that that is false. Now, a lot of papers think that we set some incorrect standards in neonatology. And I think most preterm infants are not growth failing. Number 2, environment, birth size, course. And I think if you won't be surprised that I believe that that is true. Question number 3, infants with growth restriction in utero expectations than those without growth restriction. And my answer is true. Infants should regain their birth weight percentile by 40 weeks of postmenstrual age. And I believe that that is false. So my conclusions for you, my takeaway messages are: aim to meet nutritional needs for all infants, aim for growth that's approximately parallel to growth chart curves, and number 3, to see a range of sizes and a range of growth rates. And then I'd like to invite you to enjoy song, which stands for the Society of Neonatal Nutrition, Gut and Growth. And this to collect nutrition guidelines and growth guidelines, as well as we're hoping to have probiotic guidelines, and we will be rating the guidelines for whether they are evidence-based, consensus-based, to give all of you context. And we hope this website, www.ucalgary.ca/neonatal growth. We welcome you to go to the membership page, or maybe it's on the first page, I forget, and sign up. And then we hope to get emails going out to members at some time soon.